we are talking about therapy and not drugs.
Mm-hmm. Wonderful. Good to know that we are
Yeah.
working on so much research
Yes.
now.
You're talking
Yes.
about unprotected left main or protected left?
Unprotected left main. Unprotected left main.
Okay.
And that the purpose is to find out imaging guided versus non-imaging guided angioplasty. So uh, there is yearly generation of data as far as intervention goes. Like in foreign countries, it is mandatory that you document all processes on an online portal. But here in India, it is not so. We don't have that kind of data collection. So in India, we have a voluntary data collection. Every year, we collect our data and give it to the National Interventional Council,
Mm-hmm.
which is a body generated by Cardiological Society of India. And from that data comes the details about which center does what is the implication, and what are the results. And this is one such initiative that now we want to look at prospectively how India fares in doing this kind of complex intervention
Mm-hmm.
with imaging guidance versus non-imaging guidance.
Okay. So thank you, Chirag, for this
Yeah,
informal
yeah,
beginning of the meeting. We are already live
yes,
on the YouTube now.
right.
So good morning. Welcome back to Saturday Club of Baroda morning meeting. And today we have with us Dr. Chirag Seth, a very well-known, eminent cardiologist of Vadodara. And he had been our guest speaker a couple of times earlier also. Initially, he had talked about updates in coronary interventions, and later on he had talked about pacemakers. So today he is going to inform us about what are the recent updates in lipid reduction. To briefly introduce Dr. Chirag Seth, he is MD DM cardiology. His initial training was at Lucknow SGPGIMS. Then at King George Medical University, he got his DM. And he got his further training in electrophysiology at Escorts Heart Institute, New Delhi. He has more than 2 decades of vast experience, and he has several publications in reputed index journals, national and international, to his credit. And of course, he is invited as faculty in national and international academic meets. So over to you, Dr. Chirag. Thank you for joining us. You can talk about for 40-45 minutes. And of
Yeah,
course, we'll have some interesting discussion after your talk is over.
yes,
So over to
yes,
you, Chirag.
yeah. So thank you, Dr. Satish Pandya, sir. It's always a pleasure to speak on this forum, and I'm more than happy to be here. So let's go ahead with lipid update. And I'm sure our interaction will be more interactive in the later part of the
Yes.
talk. So let's start. So as we know now with coronary imaging, we are able to see the coronaries directly. And this is one such picture showing structure of coronary artery, where you can see how the intima looks, how the media looks, how the adventitia looks. And these are some of the pictures about how the diseased artery looks. Like here in the bright thick structure, it is called intimal fibrosis. Whereas if we see here, this anechoic or less echoic space is a collection of lipid. And if you compare with the next image, you can see that it is on a fibrotic image, fibrotic plaque here. So this is a lipid-rich plaque, and this is a fibrotic plaque. This is covered by a very thin uh, a layer of fibrous tissue. So this is called a thin cap fibroatheroma. Whereas here, the fat collection is covered by thick cap of fibrous tissue. This is called a thick cap fibroatheroma. Why we want to know this? Thick cap fibroatheromas, they do not rupture easily, and they present with chronic coronary syndromes like exertional angina kind of symptoms, whereas thin cap fibroatheromas are called vulnerable plaques, and they tend to rupture and cause acute coronary events. So these things are, we are able to now know with the help of coronary imaging how the end result of atherosclerosis looks, which leads to coronary events. And these are in brief just to show how imaging has revolutionized our treatment methodologies. Like you can detect thin cap fibroatheromas. You can find out how the lipid-rich plaque versus fibrotic plaque looks. You can see plaque vascularity because you can see microchannels in the plaque, which can indicate that plaque is now inflamed. There are macrophages which can be directly seen. This bright structure with a shadow behind is a macrophage. Then we can see the extent of calcium inside, and we can see cholesterol deposits like a bright spindle-shaped structure. This is cholesterol. Then we can see the crystal. So now sclerosis and design our therapy as far as intervention goes. So when the sciences progress so much, ultimately we have to go back to what has led to this and are there any good predictors? Because ultimately our job is not to treat all this when they progress and present as acute coronary event. Our job is to prevent at the community level how these events can go down. And therefore, this slide shows what are the predictors of aggressive atherosclerosis, which are the people who have aggressive atherosclerosis. When they come to the OPD, how do you find them out? So most importantly, at advanced stage, those who have heterozygous familial hypercholesterolemia, those who have prior angioplasty or bypass done, of course, diabetes, hypertension, chronic kidney disease, current smoking, those who have persistently elevated LDL cholesterol level higher than 100 despite being on statin therapy, those who have history of heart failure. These are clinical markers where we think that these are the patients who are going to have aggressive atherosclerosis. But I think this slide is more important to us. Which are the risk enhancers of atherosclerosis? Like the previous slide, all these features are very well known to us: diabetes, hypertension, smoking, so on and so forth. But these are other groups of patients where we should be paying attention to, and we often tend to neglect in day-to-day clinical practice. So one most important is family history of premature heart disease. If someone in family has a heart disease less than 55 years of age, we need to understand that other family members need to be screened, especially first degree relatives. Those with elevated LDL levels higher than 160, those with metabolic syndromes, conditions specific to women. I mean, females have been often neglected considering that they have hormonal advantage and they don't have much of heart disease. But it's a wrong notion, and we need to understand that all those who have preeclampsia, those who have gestational diabetes, those who have collagen vascular disease diagnosed in young age group, let us say lupus or rheumatoid arthritis, premature menopause, these are all people who are at high risk of heart disease. Ethnicity, most importantly, we being in South Asia, the South Asian ancestry has been documented as having a higher risk of atherosclerotic cardiovascular disease. Persistently high triglyceride, which we commonly have in India, being a large diabetic population with less emphasis on healthy lifestyle, adverse dietary adverse diets, and sedentary lifestyle. Uh, Among other measures, what is important is lipoprotein small a levels. Now, we currently measure LDL cholesterol levels. Often, our conventional lipid profile does not include measurement of lipoprotein small a. So, this lipoprotein small a levels are usually less than 30, but when the levels are higher than 50, it is considered one of the high risk feature because it indicates and it is a surrogate marker of future adverse coronary events. And these people are at higher risk of acute coronary events, stroke, and they have high vascular thrombogenicity. ApoB levels, which are transferring LDL cholesterol in the circulation higher than 130, is also considered as one of the risk factors for aggressive atherosclerosis. So I think these are important clinical markers which we need to evaluate in a given patient as far as heart and vascular disease evaluation is considered. So I'll start with one small example. Let us say this is one lipid profile in front of us, and this is a typical lipid profile report that you will be encountering. So if we see this report, our first impression is what is LDL cholesterol? So your LDL cholesterol is 106. Non-HDL cholesterol, which means how do you derive this value? From the total cholesterol, you subtract the value of HDL cholesterol. That gives you non-HDL cholesterol. And non-HDL cholesterol is a combination of all bad cholesterol. So after LDL cholesterol, you tend to see what the non-HDL cholesterol level is. And finally, you see HDL cholesterol level. So that is 42. And level of triglyceride 132. Now, if this is the patient, this is the lipid profile in front of you, you can see normal values written lower down. So normal value LDL cholesterol, it is written less than 100. So we are nearer to 106. So profile is not that bad, right? Triglyceride levels should be less than 150. So this person has got a triglyceride level of 132. So that is also normal. HDL cholesterol is 42. So typically this is what we find in Indian patients. HDL is not significantly elevated in our group of patients. Lower than 40 is called low. So this value is 42. So low normal kind of HDL values. So this lipid profile in general does not tell us that there is something really adverse as far as profile is concerned. So if this is a patient who, let us say, comes up for primary prevention, a just checkup done as a part of health checkup plan, and this is a report, what would you advise to a given patient? Looking into the lipid profile, probably our emphasis will be on lifestyle modification, that their diet and exercise pattern, everything should change. And since this lipid profile looks to be within the normal range, right now no medications are necessary, and that patient should be just kept on regular monitoring. So this lipid profile is actually looking like a normal lipid profile, acceptable values, and you will just go for screening for potential risk factors for heart disease, mainly in the form of diabetes, hypertension, smoking, so on and so forth, and try to reduce all those risk factors at community level. So I think this is how the approach for primary prevention would be. But now let us say if this is the patient for secondary prevention, what do you do? Let us say that means, let us say this is a patient who has come to us with already diagnosed heart disease. He already has a stenosis documented either on CT scan or coronary angiography, or let us say his treadmill is positive, or let us say this patient has previously described risk factors for heart disease. So if that patient has this kind of lipid profile, then definitely this lipid profile has to be treated. So I think this is most important concept that all of us need to be understanding, that if patient already has high risk features for coronary artery disease, more than two risk factors for having heart disease or diagnosed heart disease, in all those patients, whatever LDL cholesterol level is, you need to treat that with help of lipid reducing agents, most importantly statins that as of now we have. And the target is that you reduce LDL levels by 50%. So if you have levels of 106 in a given patient who already has established heart disease, your target LDL reduction should go down to 50s, right? So that may look radical, like such degree of lipid reduction now is a recommendation, but we need to understand that these kind of lipid levels are nowadays we are commonly encountering. And if we see our group of patients, Indian group of patients, they have much more aggressive atherosclerosis found. And we have now understood that even these values need reduction. So the current guideline is to reduce these levels by 50%. So let us go into little details of further strategies. So this is one such study documented from Journal of American College of Cardiology way back in 2007, where they have shown that normal LDL cholesterol levels are associated with subclinical atherosclerosis even in absence of risk factors. And what did they show? They studied patients with differing values of cholesterol, right from 50 to 60, right up to 150 to 160. These are values of LDL cholesterol. And on the y-axis, the extent of atherosclerosis is documented. And they evaluated with Doppler studies and ultrasound which vascular sites are involved, whether zero vascular sites involved, one vascular site involved, two vascular sites involved. Let us say coronaries and carotid circulation, coronaries and peripheral artery disease circulation. And what they found was that beyond the level of 60 milligram per deciliter of LDL cholesterol level, increasing levels are associated with increasing involvement of atherosclerosis, which was subclinical, right? So there is no such value called a normal LDL cholesterol. Higher the value, you are going to have higher degree of atherosclerosis, even though subclinical. Lower the value, lower is the chance of atherosclerosis, even though subclinical. So this drives a concept that lower is the better, and higher the value, you are likely to have higher levels of atherosclerosis, higher severity of atherosclerosis involved. Now let us say that patient that we have discussed is now coming up with this report also. Lipid profile, now commonly we encounter with this kind of reports also. We also order them that not only lipid profile should be seen, but apolipoprotein levels also should be seen, and lipoprotein small a levels also should be seen. So this patient has, let us say, lipoprotein small a levels of 84.8. Mind will be discussed in early part of my talk that levels less than 30 are normal. And when you have such high levels, 84.8, this puts that given patient into a very, very high risk category. This patient, despite benign looking lipid profile, is at high risk of developing major atherosclerotic coronary or carotid events. This value is an ominous sign, right? So there is this study which is published recently, JAC 2024, which has documented how bad the lipoprotein small a is. So lipoprotein small a is markedly more atherogenic than LDL. It is an apolipoprotein B based genetic analysis study, and they have come out with a conclusion that it is 6 times more atherogenic. So even though benign looking LDL cholesterol levels, if the same patient has got very high lipoprotein small a levels, that puts that patient into a group which is more prone to adverse heterogeneity and high risk group. Now coming down to the data which says that lower levels are more important, and how do you restratify them further. So this is one such study which has studied LDL cholesterol levels in patients who have undergone angioplasty and they have already achieved low levels. Let us say less than 70 milligram per deciliter of low levels of cholesterol has been achieved in that given patient. So they studied all those patients who have already achieved less than 70 milligram per deciliter of LDL cholesterol levels and tried to find out, are they at future risk of coronary events or not. Like once the low levels are achieved, one would feel that, oh, now I have achieved good levels of low cholesterol, now I don't have any more risk. But no, it is not so. Many patients continue to have residual inflammatory risk. So how did they identify? They identified with the measurement of C-reactive protein levels. And they found out that those patients who continued to have high CRP levels at two subsequent visits within first year after undergoing angioplasty, they are at much higher risk of developing major adverse coronary events by the end of first year compared to those patients who have low CRP levels or normal CRP levels. So it adds to one more dimension, that not just low lipids, but inflammatory milieu at the level of vascular endothelium, which you can decide based on CRP, high sensitivity CRP level assessment. If HSCRP levels are high, all these patients are also at high risk of future coronary events. And what does it practically mean? That all those patients whom you have achieved less than 70 milligram per deciliter of LDL cholesterol levels with statin, if these patients have high CRP levels, you should be targeting even lower LDL cholesterol levels to reduce their risk of future coronary events. Because wherever the lipid cells are incorporated into atherosclerotic process, they invite inflammation. So higher the lipids, higher the phagocytic cells, imbibing them inside and developing foam cells, ultimately causing more and more atherosclerosis. More atherosclerosis means more inflammatory milieu at the level of vascular endothelium. So both processes are ultimately interlinked. So whenever you have inflammatory markers high, you need to consider all those patients to have even lower LDL cholesterol levels, targeting even less than 50. So these are, in nutshell, emerging concepts in treating dyslipidemia, which says that progression of atherosclerosis is linear, parallels lifetime exposure of LDL cholesterol levels. How it is important? Let us say newborn LDL cholesterol levels are less than 20. By the age of 9 to 12 years, those levels gradually increase and reach a plateau. And after 12 to 15 years of age, whatever LDL cholesterol level is, it is based on mainly your diet and a lifestyle. So it is possible, because we don't have a linear data in lot many patients, we still have to understand that low levels are actually the norm, and physiologically that is what we are born with. Whatever we have it in adult age group, those levels are really very high, and those levels definitely need to be controlled down if we need to hold the progression of atherosclerosis. So target LDL-C reduction needs to be titrated individually for every patient. Cutoff of 70 milligram per deciliter of LDL cholesterol always does not translate into reduction of major adverse coronary events. And what is important is that South Asian or Indian ancestry with elevated levels of lipoprotein small a adds to the complexity of management, because it identifies much more high-risk subgroup of patients who have dyslipidemia, right? So then comes the concept of LDL cholesterol variability. So we know diurnal variations. We know the diurnal variations are physiological. Variation heart rates are physiological, right? So let us say with exercise, heart rate going up, during sleep, the heart rate going down is physiological. Rather, if the heart rate is non-variable, it is pathological, right? Because it says that there is something wrong with autonomic system. Variation of BP again is considered pathological, because even though you have a good BP control, if your BP tends to fluctuate more, it is a risk of stroke. So variability is a norm in our day-to-day assessment of patients, and it is important now to understand this kind of variability happening in LDL cholesterol as well. What does it say? It says that even in a given patient, if LDL cholesterol levels are variable at 2 or 3 time points, cumulatively it adds to exposure of particular LDL cholesterol, and that adds to 10-year atherosclerotic cardiovascular disease. And therefore, you should have a smooth levels of low cholesterol values. Let us say your value is 70, at one point of time it is 90, at another point of time it is 104, at another point of time it is 84. So all those values, those seemingly looking benign, but the values are variable at different time frames. So the higher values will be associated with some progression of atherosclerosis, low values will be associated with some halting of the progression of the disease. So it is said that every peak, every excess levels happening in the background of previously low levels will be associated with some progression of atherosclerosis, even though absolute values from the lab reports point of view may be falling into normal zones or low normal zones. So lipid variability is an important concept, and now it is being recognized that that also adds to 10-year atherosclerotic disease progression presenting as adverse clinical events. So there is this study 2015 published in again JAC by Sripal Bangalore et al., which says that visit to visit LDL cholesterol variability is associated with adverse outcomes. The insights they had shown from the TNT trial, and what they showed was that every one standard deviation increase in LDLC variability translates into this kind of adverse clinical outcomes. So this is what translates into this kind of adverse risk of MI, 23% high risk of mortality, 11% high risk of NECV events. So this is what has been already been understood, shown into clinical trials. So if we come back to our clinical practice patterns, how many patients with established cardiovascular disease are on high dose therapy for long term? Like if we talk of our own practice, most often what we do is we target low levels of cholesterol, and then we try to reduce down the cholesterol levels, understanding that probably low levels of statin also will control those patients in long term with low levels of LDL, which is sadly not true. If you lower down the dose of statin, there are chances that in next 3 months, 6 months, those lipid values will again start rising, unless you're really monitor those patients very closely. And that's why reduction in that particular dose may add to a component of LDLC variability, which may translate into plaque progression. So this is in nutshell the extent of lipid reduction which we find with statins versus newer drugs which are available, which is PCSK9 inhibitors. Statins typically tend to reduce cholesterol levels by 20 to 24%. Newer drugs which are PCSK9 inhibitors, uh, important groups are two. One is monoclonal antibodies. When they are given with statins, they tend to reduce cholesterol levels to the tune of almost 40 to 50%. Inclisiran is again a very newer drug, latest addition to our armamentarium in lipid reduction, which is actually a small interfering RNA drug, and that also translates into lipid reduction by 45 to 50%. So these are the emerging tools that now we have for lipid reduction, and it is important to adhere to the therapy. Like when we ask the patient to continue taking long-term statins, we know the compliance always becomes an issue. And when we need such high degree of aggressive lipid reduction, most patients need high dose statin to be continued. That means either 40 milligram of 20 to 40 milligram of rosuvastatin or 40 to 80 milligram of atorvastatin. And at times this high dose of statin leads to compliance issues, cost issues, and some side effects. Like statins typically may cause some degree of myalgia, fatigue, weakness, which are common as far as statins are common. Statin use is common in long term. Of course, they are not as common. I mean, let us say typically less than 2 to 5% of people tend to get it, not really very common. But compliance definitely becomes an issue for chronic therapy, as we all know. And therefore, these drugs score, newer drugs like monoclonal antibodies and inclisiran, they are to be given in injectable form subcutaneously, and they are to be given periodically and not the daily therapy. And therefore, now it is being projected that these drugs are likely to reduce lipid variability, and consistently they will reduce cholesterol levels much more than what statins offer, and they are likely to be translating into much more clinical benefit than what the statins have given. And now there are data emerging that kind of benefit happening in actual clinical practice. So So the latest 2023 European Society of Cardiology guidelines have asked for lipid reduction to the tune of less than 55 milligram per deciliter, and at least from the baseline it should go down by 50%. So either of the two targets have to be achieved. That is what European Society of Cardiology recommends. And for patients who experience a second cardiovascular event, let us say someone has developed myocardial infarction and within 1 year he develops a stroke also. So this is a second cardiovascular event. So these are the patients whom LDL cholesterol level goal has to be less than 40 milligram per deciliter. So that is very aggressive level of lipid reduction. And that they have shown, that appears to have shown additional benefit as far as preventing future events are concerned. If we talk of Indian data, we were discussing at the initiation of talk how the Indian data are coming up. So this is one such Indian study which have shown what is happening in India as far as use of cholesterol post angioplasty is concerned. And what they have shown understand is that if we look into our patients who have undergone angioplasty and put on high dose of statin and monitored them over a period of 1 year, what has been found that even though guidelines recommend less than 55 milligram per deciliter of dose, 79% of patients have not achieved that target of less than 55%. Close to 55% patients have not achieved target LDL cholesterol of less than 70 milligram per deciliter. So there is huge gap between what the guidelines are recommended and what we are able to achieve practically, even with currently available moderate to high dose statin therapy. So there are some gaps which we definitely need to be filling up if we want to reduce this burden of atherosclerosis. So, and therefore, there comes the role of these newer drugs, which can help in filling up those gaps. So, the projected benefit has been shown in this slide, that curves continue to diverge over a period of next 5 years if the patients have statin versus newer drug, that is monoclonal antibodies or inclisiran group of drugs. So this is our own guideline from Cardiological Society of India 2023. Last year it came up, and because South Asian ancestry, as we know, is a higher risk profile, and as per the CSI 2023 guidelines, it classifies various modalities of risk assessment and classifies patients into low risk, high risk, very high risk, and extremely high risk group. And you can see extent of reduction that has been mentioned here. Those patients who are at extremely high risk, as documented by 10-year risk profile calculation with ASCVD risk, heterozygous familial hypercholesterolemia, and elevated lipoprotein A levels, those must have LDL cholesterol reduction less than 40. So this is the extent of aggressive lipid reduction now recommended. So the lipid profile we discussed in the initiation of our talk will definitely need statin therapy to start with, and levels have to be targeted from 106 to less than 40 according to these guidelines. And only if that person is in the levels should go variably down, either below 17 high risk, below 55 for very high risk, and less than 40 for extremely high risk. So this is how the current risk stratification strategy goes, and accordingly we need to target that degree of lipid reduction with available modes of therapy. This is one of the latest recommendation adopted from UK NHS pathway and American College of Cardiology, which says that you try giving moderate to high dose of statin for first 3 months to achieve that target level of lipid reduction. After 3 months, assess those patients for compliance and see whether these patients have achieved that target or not. If the patients are statin intolerant, they can be put on either ezetimibe after reducing the dose of statin, or they can be shifted over to bempedoic acid. These are again two new drugs which are there to add to statin therapy, and one can have a dual lipid reduction therapy. That means you can have statin plus ezetimibe or statin plus bempedoic acid, or you can have bempedoic acid plus ezetimibe therapy in combination, or even triple drug therapy to achieve a particular target reduction of LDL cholesterol levels. And by 3 months, if those patients are unable to achieve that target reduction, they should be offered monoclonal antibodies or inclisiran as a more effective and more aggressive lipid reduction therapy for all those patients at the end of 3 months. So our approach is emphasized that it should be more and more aggressive in achieving highest degree of lipid reduction. A few brief points about inclisiran. It is a small interfering RNA. The research started from early 70s, that is 1970, and now we have drug with us. What inclisiran does is that it this is a PCSK9 molecule here, LDL receptor complex, which imbibes the LDL cholesterol. And this internalized complex is taken up by endocytosis, and that undergoes degradation. What inclisiran does is that inclisiran inhibits this PCSK9 molecule. So what internalizes is only LDL with LDL receptor without PCSK9. So this does not go actually degradation. What it does is, rather than degradation, it frees the receptor, which returns back to the surface. And therefore, more and more LDL receptors are available on liver surface, which can clear off circulating LDL cholesterol levels. So this is the mechanism of action of PCSK9 inhibition. And inclisiran acts in inhibiting this molecule in the cell wall, that is PCSK9. So the typically inclisiran demonstrates efficacy and sustained LDLC reduction, and therefore it also translates into lower inter-individual variability. And multiple studies now over a period of last 5 to 6 years, now we have data of almost 6.5 years documenting its safety and efficacy. And numerically, definitely low numbers of MI, lower number of stroke, and almost 26% reduction in composite major adverse coronary events over a period of 18 months was shown in Orion 9, 10, and 11 trials. So now we have data of almost close to 7 years, more than 8,000 patient years, and except for injection site reactions and some patients coming up with bronchitis, which is benign, no other major side effects. Major side problem with our class of patients is going to be compliance, because this drug is costly. A single dose of inclisiran costs about 1.25 lakhs at present, and initial doses to be given as stat, second dose at 2 months, and thereafter every 6 monthly. That is what the recommendation is as far as giving inclisiran is concerned. And it is a pre-filled syringe dose, single dose, no dose titration, and it should be given subcutaneously. So this is supposed to improve the compliance if we are taking into account the cost issues. If the cost issue is taken care of, then this is going to be a marked revolution in our lipid reduction therapy. So this typically shows what the dosage therapy should be: 3 months, 6 months, and then every 6 months. So there are several other molecules which are also in studies which are going to come up in next 1 year or two. So inclisiran not only reduces LDL cholesterol levels, it also reduces lipoprotein small a levels. Now statins reduce LDL cholesterol levels, but they don't reduce lipoprotein small a levels. Whereas lipoprotein small a levels are definitely affected by inclisiran also. Inclisiran tends to reduce lipoprotein small a levels by 20%. And newer drugs which are still under study, pelacarsen and olpasiran, these are the two new drugs acting on similar pathways of PCSK9 inhibition. And with that, we are likely to achieve more than 80 to 100% reduction in lipoprotein small a levels. And these drugs, as they come into market, further will revolutionize our lipid reduction therapy. And they are going to be the tools to look forward to prevent our high-risk group of patients. So I think I end the talk with these key takeaways: that increased LDL cholesterol levels are directly linked to atherosclerotic events. Sustained reduction is important, and sustained reduction in variability is important, which can lead to proportional reduction in high risk of patients developing atherosclerotic disease. Despite high intensity statin therapy, high cholesterol levels may occur due to poor adherence. In these group of patients, inclisiran and monoclonal antibodies can help in achieving further lipid reduction. And thank you for this patient hearing. Thank you.
Thank you, Dr. Chirag. Please stop the screen sharing. Yes.
Yeah.
Yes. So as expected, wonderful, very informative talk, and very exciting things are happening, it seems, in the area of lipid reduction. And I'm sure there are a lot of questions among the audience. So now we are open for any questions, comments.
Yeah.
Please.
I have a question regarding Lp(a).
Yeah.
The Southeast Asian population is supposed to have a normal value of more than 30. Have we standardized that for our Indian population as to what it should be? 30 is for Caucasians, as far as I remember. For us, it should be at a higher level.
So I believe our so-called normal values, which we define, is again proportional to our population studies. And we still have to understand that large subgroup of Indian patients do have high levels. And when we are unable to explain lower levels of LDL vis-a-vis Western population, we have identified that it is a high level of LPA which is problematic. So LPA level which are okay for Western population are not okay for our population. So even 30 accepted for Western population should be high for our group of patients because we need to definitely reduce those levels because we have seen that atherogenicity of LPA level is much more, 6 times higher than LDL. So if let us say LDL is 90, but LPA levels are high, we have aggressive atherosclerosis. And we have seen that happening actually in patients. Patients who have aggressive multivessel disease, patients who have aggressive atherosclerosis involving multiple vascular beds, they tend to have relatively low level on conventional standards of LDL, but their LPA levels are high. So many youngsters have high LPA levels with a relatively normal LDL cholesterol levels. So I believe it is wise to accept 30 as a conventional value for us also. And that way it helps our risk stratification in much better that we need to pay attention to these patients more aggressively.
Thank you.
Dr. Jagdish Sinapa wants to ask. Yes, Dr. Jagdish.
Morning, sir. Morning, Dr.
Morning.
Chirag, and morning,
Morning.
Dr. Pandya. Wonderful lecture as usual. Saturday mornings are always exciting.
Yeah.
A question I have for you, sir, is that in a patient with very low risk factors,
Yeah.
who's got an LDL, let's say around 140,
Yeah.
would you treat this patient with inclisiran, or do you think statins are sufficient, or do you think no treatment is required?
So as if you look back to my slides, what I have shown is our first drug of therapy is always statin
Okay.
because statins have decades of experience and
Yeah.
proven data. And again,
Mhm.
it is cost effective with currently available therapy. So our first target should be
Mhm.
to reduce those levels by 50%. So from 140 of LDL, our target should be at least 70. So I'll put that patient on statin high dose. So either 40 milligram of rosuvastatin or 80 milligram of atorvastatin and try to reduce those levels by the end of 3 months. If the patient has side effects because of statin, some compliance issues or side effects, I reduce the statin to let us say 20 milligram of rosuvastatin, make the dose 50% less, and add azatimib. Combination of statin with azatimib is now supposed to give a very good protection by reducing lipid levels and getting our lipid levels to the target. So by 3 months, if we are unable to achieve that degree of reduction, apart from, of course, diet and lifestyle modification, then only comes the role of advanced therapies in the form of inclisiran. So beyond two drugs, let us say the patient is on statin plus azatimib, a third molecule can be added in the form of bempedoic acid. So you can go for even triple therapy, give still more trial of 3 months. And at the end of 6 months, if the patient is still unable to achieve target levels, then the role of inclisiran group of drug comes. So
My
not for every
question is, sir,
patient.
because
Hmm.
my question is, see, you mentioned in your talk that the variability is well controlled with
Yes,
inclisiran,
correct.
and if the patient can afford, why not use that drug first?
Agreed. But to make that, I mean, if you see the cost benefit issues that even US government FDA comes out with, they are also still skeptical about accepting inclisiran on a bigger platform. The practice in US is more insurance based, so they definitely have to look into cost issues. So yes, in a given individual patient, one can think of treating if cost is not a barrier with inclisiran, definitely good, no issues. But to make up a strategy at a community level, I think this is what the approach which is being commonly followed. So in
Right, sir.
individual patient, yes, I agree that inclisiran can be given a choice.
The other point is that the table you showed that in a patient who otherwise has no risk factors,
Hmm.
the acceptable level is 100.
Hmm. True.
So would you want to bring it down to 70, or if it is less than 100, it's more than enough?
So in general, as we say that lower is definitely better. If there are no risk factors, then
Yeah.
less than 100 is fine. But
Okay.
I would draw your attention to that particular slide, which says that South Asian ancestry is also a risk factor.
Okay.
So for majority of our group of patients, I would still feel that less than 100 achievable is good. But if you're able to achieve less than 70, it is going to be even better.
And is it practical that you can reduce it to less than 70 by pure lifestyle modifications?
Unlikely. So alone lifestyle modifications do not.
Okay,
Diet and
okay.
lifestyle modification alone are not helpful, and
Hmm.
therefore we have to understand that to this level of reduction we need to achieve with the help of statin only, and therefore we are talking about this compliance issues that for a healthy individual, if I ask that you need to take statin to keep your level less than 70,
Hmm.
acceptability is definitely going to go down. And that's the
Correct.
real problem in a low risk group of patients. And therefore, to translate this, let us say if you want to see these patients in 20s and 30s, how do you
Yeah.
convince them that your future risk may be high and you need to take it today? So
Correct,
this
correct.
requires a lot of awareness at community level and a lot of emphasis on lifestyle modification as a first tool and then statins.
Another question I have is regarding use of low dose aspirin.
Yeah.
You think that this also should be combined with treatment for
No.
dyslipidemia?
No. It is now
No.
clearly established that aspirin is not recommended unless you have diabetes with one more coronary risk factor for prevention of future coronary events. If you have diabetes with one more coronary risk factor, then
Right,
yes.
sir.
If you
Okay.
don't have diabetes and otherwise, okay, then the aspirin is not recommended. Only high LDL cholesterol level is not an indication for giving aspirin.
Right, sir. Thank you so much, sir. Thank you so much for clarification.
Thanks. Thank you.
Yes.
On rosuvastatin, when it came out in the market, they recommended it for autistic people. The starting dose should not be more than 5 milligrams per day. Is that
Hmm.
still true, or we can jump right away to 40?
No. Typically, we put all our patients who have undergone PCI, angioplasty, or bypass on high risk, high dose. That is not less than 20 and 40 definitely. So can be
Also,
started with
Chirag,
40, not an issue.
in established atherosclerosis, where even plain muscles have covered the atherosclerotic plaque,
Hmm.
reducing the lipid level, will it help?
Yes, it does help. I mean, any degree of lipid reduction definitely translates into prevention of future events, and that has been very clearly documented in multiple studies over last 2 or 3 decades. So lipid reduction definitely helps because we have to understand atherosclerosis is a dynamic process. It doesn't stop. It continues throughout your life, and every fluctuation in LDL cholesterol level adds to some progression, no regression. So the only way you can prevent is by halting that progression by controlling lipid levels and doing something which can improve your endothelial health, and that is in the form of exercise and prevention of smoking and tobacco. So I think we are unable to completely halt, but yes, these are the modes which can help in achieving that direction.
At what age first lipid profile should be done?
So current for what we have started promoting and what has been the consensus is that your first lipid profile assessment should be at the age of 20. And if that is perfectly okay, you just stratify them looking into family history and everything, emphasize lifestyle modification, exercise, diet, everything. And if things are fine, measure them every 5 yearly. If you find something abnormal, pay attention to them and you may assess every year or 2 yearly.
Dr. Chirag, with obesity on the rise amongst adolescents, I mean, we see a huge number of adolescents with obesity.
Yeah.
As a cardiologist, do you come across adolescents who seek your help for dyslipidemia?
Yeah, definitely we do see. So not only obese, but we see a lot of youngsters coming up for assessment. Those who are regular gym goers, those who are let us say cyclists. So apart from obesity, people who are health conscious, they also come up for assessment that what is their risk of developing, because we see so many instances where gym goers have developed event or marathoners have developed an event, so they want risk stratification to be done. So we encounter all class of people coming up for risk assessment, and therefore it is more important that yes, they need to be provided with adequate information supported by data and appropriate intervention right from the early age group.
With so many options available for lipid reduction, does your algorithm help to form sort of uniformity among all cardiologists in their approach to dyslipidemia, or there is lot of differences between the cardiologists.
So typically what I follow and what has been recommended in various guidelines published by American College of Cardiology, European Society or Cardiological Society of India is that in a target patient, you should always start with statin number one, moderate to high dose depending on what degree of lipid reduction you want, with targets defined less than 70 or less than 50 or less than 40. So assess at the end of 3 months. Compliance issues, either reduce the dose and add ezetimibe. Again, assess after 3 months. If you have not achieved, add bempedoic acid. Again, profile strategy over a period of 6 to 9 months will go. And if you're not achieved target levels, then the option of reserve drugs will come. So this is about strategy of which drug to use and what degree of reduction is concerned. Second part of assessment is what to target. So when you have so many levels, so many lipid subclasses given, people are mostly getting carried away by HDL. I have very good HDL levels, or my HDL levels are low. These are the typical questions, how they are going to translate into my risk. So consistently, our approach now is that make them focused on LDL alone, nothing else but LDL first. Your first target is to reduce your LDL to 50% of what you have or less than 70 to start with. So that is our first approach. Don't look at any other lipid fractions. Once you have achieved LDL cholesterol reduction, automatically you may have achieved reduction in non-HDL also. So because both these things are going to go parallel only. So both these things you have achieved at one particular time frame, then look into the levels of triglyceride. Your triglyceride level should go down to 150 or less. Let us say that person has a triglyceride level of 220. What do? Don't start on triglyceride reducing therapy. Triglyceride reducing therapies are recommended only if your values are higher than 500. You don't need specific triglyceride reducing therapy in the form of fibrates when the values are less than 500. It is mainly your diet, that is saturated fats and sugars, that you need to cut down, and look for additional causes. Let us say thyroid disorders, drugs, let us say thiazide group of diuretics. Typically, patients who are on those therapies, they can lead to dyslipidemia. So primarily, triglycerides are not our target. So if a given patient comes to us with, let us say, 100 of LDL cholesterol and 250 of triglyceride, what should be your target reduction? Some people will start with fibrates to reduce triglyceride levels because that value looks bad. So we have to drive the point that most important at any given point of time is LDL, LDL, LDL only. So try reducing LDL with diet, lifestyle modification, if required statin. From 100, let it go down to 50. Don't bother about triglyceride. That should be controlled more with diet and lifestyle modifications. Triglyceride less than 500 is not risky. Higher than 500 may lead to issues with pancreatic issues, abdominal pain, and so on and so forth. So those values are to be given least importance. More importance should be given to LDL reduction. Triglyceride, use it as a surrogate marker to find out people who need lifestyle modification, in nutshell, that they need to work upon their diet and exercise more importantly. So this is how our typical approach would go. And this is what has been the current standard recommendations. And now there is increasing convergence among physician fraternity as well as cardiologists that this is how the way forward should be.
Good. Very good information. Now, one more question regarding side effects of statin.
Yes.
I mean, we get some myalgia or say fatigue. If we continue statin, will it, I mean, overcome this side effect, or we have to reduce the dose, or even may discontinue? When do you decide to do that?
Correct. So typically what we do is that side effect translates into poor compliance. So definitely they need to be looked into, because those patients, even if you say that no, you have to take it, ultimately at the end of the day, they will not take it. One of my patient did not take it because he read somewhere that it leads to reduction in testosterone levels. So despite being in high risk group, he stopped taking statin for 4 years and developed recurrent events in those 2 years. whatever benign we feel as a clinician need to pay attention to. If it is something which affects that lifestyle, definitely we need to advocate reduction in the dose. And now, at least in last 2-3 years, we have these molecules which have found resurgence. Let us say ezetimibe, it is available for a long time, but now we have using it more frequently, understanding that compliance issues will come up. So reduce the dose of statin and add ezetimibe, or even remove completely statin and put them on bempedoic acid, which does not have statin-related side effects. So now we have two more drugs apart from statin, which can be used for these kind of issues. Simple myalgias may go away with looking into attention to, let us say, there are some data to say that good hydration tends to prevent lipid-related side effects, and vitamin D levels, if they are normal, then their side effects can be minimized. We don't have very hard data which are the strategies which can prevent those kind of side effects, but these are initial measures which, if it does not translate into benefit in a week or two, we change over. We
Right.
don't ask the patient to keep certainly on this drug for long term.
Great.
And they are ominous if they are associated with enzymatic rise. If the patient has myalgia, we always check with CPK total and CK-MM levels. Documented there is no rhabdomyolysis or myopathy happening because of statin. Those incidences are very rare, but some patients can have it. Rhabdomyolysis leading to renal failure, we've encountered only in 2 patients in 20 years, but it's a definite issue that we need to be vigilant about. So profound side effects are very rare. Most often they are benign, but they are bothersome. And whenever we encounter, we change over.
So any other questions or comments from the audience? We have about 5 minutes still to go.
Yeah.
Any role for coenzyme Q10 for myalgia?
No typical role. Not in skeletal muscular etiology, neither in myocardial etiology. So many patients or cardiomyopathy are on CoQ, but no definite benefit. May give, may not give.
Thank you.
Right.
So it seems there are no more questions. So thank you, Dr. Chirag. It was wonderful, as usual, very informative, and the interactions were also very interesting. So thank you all for joining. Thank you, Chirag.
Thank you.
We meet next Saturday morning again. Thank you all.
Thank you. Thank you very much, everyone.